Hello everyone. In this episode of Learning Pharmacology, I shall discuss a case and rational use of anti-diarrheal drugs. A brief description of the case is a 62 years male with prostate enlargement and psychosis. He was taking olanzapine 7.5 milligram per day since last 2 months and no other drug was given because prostate was asymptomatic. He developed diarrhea recently, that is 5 to 6 loose motions in quick succession within hours, and the local GP prescribed oral solution, explained it along with tablet D-fletro to be taken 2 tablets instead and followed by 1 tablet 4 times a day to stop diarrhea. He took about 12 tablets in 2 days. His frequency of loose stools decreased by the second day, but he developed dryness of the mouth and frequent urination with difficulty in passing urine, that is strangury also. Now the questions are, what is D-fletro? How does it reduce diarrhea? Is the use of D-fletro-like agents justified in diarrhea? Why have urinary symptoms appeared after use of D-fletro? Has olanzapine contributed in urinary symptoms? And which drug, based on the pharmacology knowledge, should be preferred as anti-motility, anti-diarrheal agents if required in functional diarrhea, particularly in elderly? The D-fletro contains diphenoxylate 2.5 mg and atropine 25 microgram per tablet. The dose of atropine is far below the therapeutic dose of about 1 mg parenterally or 2.5 to 10 mg orally as atropine methonitrate. Diphenoxylate is an important anti-motility drug belonging to meperidine derivative, that is pethidine called as India, mu agonist that has anti-motility effects on the intestinal musculature and therefore it reduces loose stools. It is sufficient alone in a dose of 5 to 10 mg given immediately, followed by 2.5 to 5 mg 3 to 4 times. A maximum dose is 20 mg per day. It is used for short term to control the intestinal motility. It is indicated for non-infectious diarrhea in adults above 13 years of age. It has abuse potential because in higher doses it crosses blood-brain barrier. Atropine in lower than therapeutic doses is used with diphenoxylate to reduce the abuse potential. It is stated that atropine causes weakness and nausea, so it discourages the craving. However, atropine even in low doses may show systemic adverse effects, particularly in elderly, and may cause poisoning in children if large number of tablets are taken. Atropine alone is not preferred in diarrhea because it will produce unacceptable peripheral anticholinergic effects. Now, olanzapine is an atypical longer-acting antipsychotic. With fewer adverse effects, it is least likely to cause extrapyramidal syndrome like clozapine. However, it has a potent anticholinergic action which is seen in higher doses more than 10 mg daily. Olanzapine therefore can contribute to obstructive urinary symptom in this patient, and the combined use of the D-fletro that contains low doses of atropine plus anticholinergic action of olanzapine both have actually contributed to obstructive uropathic symptoms in this patient because he already had asymptomatic prostatic enlargement. It has caused the bladder neck obstruction. All diarrheas do not require antibacterials. Viral diarrheas, secretory diarrheas, diarrheas due to carcinoid syndrome, diarrhea and thyrotoxicosis, diarrhea predominant irritable bowel syndrome, inflammatory bowel disease, ulcerative colitis, chronic pancreatitis, steatorrhea, tropical sprue, and drug-induced diarrheas, particularly anti-cancer drugs, colchicine, emmetin, and prokinetics. They will require a specific treatment, but not the. Now, there is a limited role of anti-motility agents in diarrhea. Mild to moderate non-infectious diarrhea usually improves with ORS and prevalence is a self-limiting. A specific antibacterial agent will be required if there is a known bacterial, especially Shigella or coliform organisms, and protozoal diarrhea. If the frequency is too high in functional diarrhea, then antimotility agents are approved for the treatment for a limited period of time because the reduced motility is needed. However, reduced motility may increase the resident time of the toxins that may get absorbed and cause toxic manifestations in the form of toxic metacolon and paralytic ileus. And this has been reported particularly in children. Antimotility drugs are avoided in ulcerative colitis because the ulcerations may aggravate, pain may increase. The antimotility and anti-secretory agents which are currently used are diphenoxylate atropine, diphenoxin atropine, loperamide, resicadotil, codeine and paregoric are rarely used nowadays. Loperamide is again related to diphenoxylate, an opioid, and it reduces intestinal motility by acting on the mesenteric plexi mu receptors. It causes constipation. It has least abuse potential because it doesn't penetrate blood-brain barrier because it is extruded by P-glycoprotein there. Concurrent use of P-glycoprotein inhibitors such as verapamil will increase the absorption, bioavailability, and CNS penetration, may cause CNS adverse effects, and is known to cause cardiovascular toxicity. Therefore, such combinations should be avoided. It should be preferred over diphenoxylate because of greater efficacy and considerably safety profile. It is not combined with atropine because it has shown mild anticholinergic action. The usual dose is lower because it is more potent to diphenoxylate. The dose is 4 mg initially followed by 2 mg after each subsequent low distol. Maximum dose should not exceed 16 mg per day. And the duration of treatment should not be more than 2 days or 3 days and should be discontinued. The recommended dose for children are lower depending on the age of the patient and is not recommended in younger children than 2 years of age. Now, resicadostrel is primarily an anti-secretory agent, and that is the inhibitor of a neutral endopeptidase enkephalinase in the intestines, and therefore it increases the effect of enkephalins which are secreted by submucosal and mesenteric plexi in the gut. And these enkephalins normally act on mu and delta receptors to reduce intestinal secretion by reducing formation of cyclic AMP. Because resicadotril reduces inactivation of enkephalin, therefore enkephalin action is increased and diarrhea is controlled. Adult dose is 100 mg 2 to 3 times daily, but not more than 7 days in functional secretory diarrheas. Adverse effects are there, itching, headache, but less likely to cause constipation because anti-motility action is less than anti-secretory action is more, and it has been considered to be safer in children also. Now, there are drugs for specialized diarrhea that should be used. For example, clonidine is used in opioid withdrawal diarrhea and diabetic gastropathy, autonomic GIT disorder with diarrhea. Octreotide is a somatostatin analog and has been used in dumping syndrome, and it reduces portal pressure used in variceal bleeding. It has been found useful in acute pancreatitis because it inhibits pancreatic secretion. Telotriestate ethyl is a newer agent. It reduces diarrhea associated with carcinoid syndrome because it inhibits enzyme tryptophan hydroxylase, which is a rate-limiting effect in serotonin synthesis. Mesalamine is indicated for ulcerative colitis, diarrhea, cholestyramine and cholecalciferol for bile salt diarrheas, particularly in Ehlers-Danlos syndrome and distal terminal ileum resection. Crofelemer is a purified oligomeric cyanine derivative from the dragon's blood, a reddish latex like sap of the South American euphorbia, a thick plant. This botanical extract is used for the treatment of diarrhea that is associated with HIV and anti-HIV therapy. Rifaximin is basically a topically acting rifamycin derivative that inhibits bacterial protein synthesis in gut. It is not absorbed and therefore is mostly excreted in the feces. It has local antibacterial action on the pathogenic microbiome in the intestine. It is indicated in diarrhea predominant irritable bowel syndrome, and because of short half-life it is given in a larger doses for three times daily for 2 to 3 weeks. Other uses are traveler diarrhea and hepatic encephalopathy. This may cause some enzyme elevation, Clostridium difficile superinfection because of local broad spectrum action, nausea, vomiting, and dizziness. Other agents which have role in diarrhea I will not discuss in detail. There is a definite role of zinc in childhood diarrhea, increasingly realized role of pre and probiotics. Berberine has anti-secretory and antibacterial action, has been used as a time-tested medicine for diarrhea in children and adults. Carboxymethyl cellulose is a bulk-forming agent, and bismuth salts also act as antidiarrheals. The key points, takeaway points are antimotility drugs should be used judiciously only. One may prefer a safer antimotility agent such as resic-adrotil or loperamide over diphenhxylate atropine combination. Always take history of the concurrently used drugs to avoid adverse drug-drug interactions, particularly in elderly, as in this case. The full therapeutic doses of atropine-like drugs will cause systemic adverse effects and will not be useful in at all ages and particularly in elderly, where it will cause obstructive uropathy and precipitation of glaucoma. Mainly commonly used drugs are the hidden form of the anticholinergic atropine-like effects, antihistaminics, antispasmodics, antidepressants, antipsychotics, particularly conventional antidepressants, antipsychotics, and some antiarrhythmics such as disopyramide have antimuscarinic action that may contribute to inadvertent adverse effects and adverse drug-drug interaction. Therefore, a good drug history will avoid this combination.